Hey everybody, good morning or good afternoon, good evening, whatever the case may be, based on where you are in the globe. My name is Liz. I'm one of the staff members here at CDH and TGH, and I'd like to welcome you to Pills, Patches, and Shots. This is the second installment in our series on gender-affirming care with Dr. Dee Haggerty. 2 weeks ago, we had our first installment, which was Tales from the Trenches. And in this installment, Dr. D will discuss the how and why of hormonal therapy and along with what you can anticipate from it. And before we get started, I'd like to bring a few people up on stage here and give a big shout out to Kimberly and Jasmine. They've been heavily involved in this facelift that we did for our video section on respective sites, and they've had an integral part in making this all happen. So thank you, ladies. How are you today? I hope you're doing great. All right, awesome. Okay, so thanks so much, ladies, for helping out. This has really it's been a pleasure working with you, and looking forward to continuing to do this in the future.
Oh, we will.
And so just want to go over a couple of housekeeping items, a few notes here. If you have any questions during the webinar, feel free to post them in the comment window, which you'll see on the right-hand side of your screen. And Dr. D will answer those questions after the presentation, unless she sees something that really needs to be addressed right away, then she'll take it then. But generally, I think we're going to be handling all the questions at the end of Dr. D's presentation. If you are watching on YouTube and you would like to participate and ask questions, please head over to either CDH or TGH and register so you can get those questions in. And lastly, we have gotten some comments about watching the webinars on mobile devices. Best we've been able to tell, you're going to have a better experience if you head over to YouTube to watch it. If you have any questions, it might make it a little bit easier. Of course, you'll still need to register to be able to do that. And so that takes care of the housekeeping items. Without further ado, I would like to introduce Dr. Diana Haggerty. Many of you know her as Dr. D. And before she set her sights on family medicine in rural Alabama, Dee taught and practiced medicine in several large metro areas around the United States, and she has been treating trans patients for over 38 years. And for the last 38 years, Dr. D has been transitioning herself, and so she has a unique perspective as a doctor providing trans care and also as a trans patient. And so, Dee, I'm going to let you take it from here.
All right. Thank you so much, Liz. I do want to second a couple of comments that Liz made. Liz, Kim, and Jasmine Marie, these ladies have really worked hard for you, our viewers and members at CDH and TGH, to make this happen. They put a lot of hours in behind the scenes, and literally they've pushed boulders uphill with their noses. Liz asked if I had seen boulder marks across her nose. Yeah, we have, because the folks, a lot of things have gone on here to bring this live. But ladies, you've made my life wonderful, and I really appreciate working with you. It's been great. All right. So for our listeners, thank you so much for taking your time on a Saturday, and for some of you, a Saturday evening, to be with us. This is our second in a series on gender-affirming care. The first episode that we had 2 weeks ago, and if you missed it, please go look at it on our YouTube channel. It was Tales from the Trenches, and that was to lay out systems of care and the care content areas that you should be looking at as a transgender patient seeking care with your group of providers. This week, we're taking a deeper dive into pills, patches, shots, all the things that we do for gender-affirming care. Now, let me assure all the folks, and I see we have folks from Australia and from UK, et cetera, here with us today. It really doesn't make any difference what continent you're on, what ocean you're across, or what healthcare system that you find yourself, today's comments and also last episode's comments really apply to all of us. These are the things that make up the standards of care and the things that apply to all of us. All right, so on to pills, patches, and shots. So I had this title, and that made a lot of sense to me, but I've been asked to do similar kinds of things for, I'll say, the DIY crowd that was doing gender and hormones without help. For whatever reason, they didn't have access to care or whatever. And so I was asked to tell them all the horrible things to happen. Well, that title was the good, the bad, and the really ugly of what we do. But I really didn't think that y'all would want to be here talking about the bad things. Well, come on, Dr. D, tell us the good things. Why are we doing what we're doing, and what are we going to get out of it? So I put it together and reframe this a bit. And I'm going to deal with the adage that we've all heard many times. Knowledge is a powerful thing. So let's know some things before we go. Now, speaking of knowing before we go, yes, this is an episode on transgender care. Well, I'm going to be talking about both transmasculine and transfeminine. And we know that most of the viewers today are going to be most interested in the transfeminine, but I want everybody to keep in mind that all of us find ourselves at some different part of the gender spectrum. But we're all part of a continuum, and we're all part of a larger brotherhood, sisterhood, and members of this community. Knowing what many of our fellow travelers face in acquiring their desired state in life really helps to foster that acceptance and shared commitment to also help all of us as we make this journey together. Okay, so my role today is to lay out this deep dive in gender affirming care. You're taking your time to come spend it with us. I'm hoping to entertain you a little bit. Hopefully you'll walk away with a couple of smiles as we talk about this. I'm going to try to obviously impart the fundamental pieces of knowledge that all of us should really have. And hopefully along the way, I will eradicate a couple of mistaken notions out there. So, who am I? Let me tell you a little bit about myself. Let me start off by saying, yeah, I really am a dinosaur. If we have some time at the end, if somebody would like to ask me what was that moment that was my revelation to help me really understand that I am, I'll be happy to discuss it. Now, you saw all those letters and things after my name. I did my bachelor's at the University of Missouri in chemistry. I then stayed there and did a master's degree in physical chemistry. I then went to Case Western Reserve in Cleveland, Ohio, and did my PhD in physical biochemistry. From there, I traveled to the National Institutes of Health and did a postdoctoral fellowship in biochemistry. After that, I wound up in medical school in Atlanta, Georgia at Emory University. And while I was a first-year medical student, I did my master's degree in public health with an emphasis in chronic disease epidemiology. Yes, I did it when I was a first-year medical student. So if you haven't figured it out so far, yes, I really am a pocket protector wearing, slide rule holster on the hip carrying kind of geeky person. But let me assure you, I can walk, I can talk, I can pat my head, I can rub my tummy, and I can do all of it in heels. So hopefully you won't be bored to death while we go through today's time together. Well, I've really classed up my act. And in the early days of TV medicine, I was a TV doctor. I had a segment on the evening news. I also had a show on Sunday afternoons, and I did that for a year. And, I got to be pretty good at stringing sentences together and not making too many blunders in public. And it was really that exposure that got me into a certain place at the right time. I was asked to be the representative for the American Academy of Family Physicians to speak to President Bill Clinton and make a speech at the White House when we were really negotiating on what needed to happen during that first round of healthcare change and evolution here in the United States. Now, I'm going to give you a little bit of a trigger warning. These next two photographs are going to contain a couple of very handsome gentlemen. And one of those was me, but not particularly the way that I would like y'all to see me. But we'll get to that in just a second. So, you've heard about that part of the professional me, but I changed a little bit after my time at the White House. So here we are. I had a chance to meet Bill Clinton following our time to talk on the South Lawn of the White House. I spent 65 minutes in a closed room with the President of the United States, and it was uninterrupted time. That was really something exciting. Now, from here, we made a trip to the South Lawn of the White House, and just behind the president there is the door that goes out to the Rose Garden. Well, we all got lined up, and I was immediately behind the president. You can see Hillary back there, and you can also see Tipper Gore back there in the left-hand corner. But I was lined up immediately behind the president and his wife, and a really big, really scary-looking Secret Service man took me aside, put his arm around my shoulder, and said, "Doctor, look out the window here. Look across the street at those buildings. On the top of that building is a group of snipers. And one of those snipers has one job, and they are pointed at you. When you walk out, you can be no closer than arm's length to the president. If the president stumbles and falls, do not reach out to touch the president. If you are ever any closer than arm's reach to the president, they will shoot you." So here we are. I was the first one to give a speech. And where do you think I was looking? My gaze is directed over there to those snipers in the distance. But anyway, we were successful doing this. Not a whole lot happened with healthcare reform at that time, if you'll remember back in the States. But this was really something that was important in that it really started to change in my professional life. What I was doing on TV and doing these kinds of things, it was a watershed for me that I realized that this was more for me than it was for me to be a representative of our community. That this was not really going to help, I'll say, us advance our life, our cause, etc. So I changed my direction a little bit. And shortly after this, I left academic medicine and I wound up here in rural Alabama where I practice medicine. And I really am pretty much an old-timey family doctor. I've delivered babies, I do minor surgery, I treat patients in the office, the hospital, the nursing home. I hold people's hands as they draw their last breath on this earth. It's incredibly fulfilling for me as a physician. A really important part of that practice is treating us, other transgender individuals. And I see at least 10 to 13 patients a week. And I've been doing this for almost 40 years, offering direct care. So I really enjoy this. And plus, as you can tell, I'm walking this path with you. So I'm going to be telling these stories from both of those perspectives. Now, in terms of personal me, I've been married for 37 years. I wish my wife could have made a little appearance here. And my wife has supported me in all phases of my life. I have two wonderful children. When I'm not playing doctor, I'm a pilot, I'm a flight instructor. So I have a great time in my life, and there's never a dull moment here for me. Okay, so let's get on to the topic at hand. We're going to be talking about the WPATH standards of care, the World Professional Association for Transgender Health. And we're now currently in version 8 of those standards of care for transgender and gender diverse individuals. The very first episode or version of the standards of care came out way back in 1979. And so a bunch of really smart people got together and they looked at the available medical literature worldwide. How are we going to bring competent and caring medical care to transgender and gender diverse individuals? Now, way back in 1979, we didn't know a lot. There weren't a lot of us to study, to do research on, etc. So where have things started in terms of our standards of care? We took what we knew in the available literature regarding cis male and cis female. What are the things that make up those cis components? What kinds of hormone levels? How do we refill their hormone levels, etc.? So that's where the standards of care started. We've continued to evolve. We've gotten smarter as time goes on, and we certainly know a whole lot more about us as transgender individuals. So today, I'm going to really try to focus on the factual information that we have and what the current state of knowledge is. And realistically, it's pretty simple. Now, every once in a while, I'll give you my personal experience, but I'll differentiate whether this is what we know and this is what we do, and these are our recipes, and versus what my experience is. And I will make value statements. Nobody's going to have any difficulty understanding where I am on certain issues. But yes, I do mess up, and sometimes I mess up pretty often. Please forgive me. Remember that picture I showed you about the dinosaur? Sometimes I'll use the wrong words. I apologize. I really am trying to mind myself that I don't offend anybody here in our audience. And if you haven't already guessed, I'm a Gary Larson fan and a fanatic, and several of our slides today are going to use Gary Larson's cartoons. All right, so here we are. Let's talk about us as patients. Now, if you come into my office, I sit down in front of you, and I want to look you eyeball to eyeball. And there's a reason, because I want to speak to your mind, but I want to speak through your mind and touch your heart. The smarter you are, the better off you are in terms of a long life that you're going to have as a transgendered individual. Now, when you come in there, let's see, I got everything from the top of your head to the bottom of your toes and everything in between. I really hope that I never meet this particular patient. Well, if I did, I kind of wouldn't know where to look, if I'm trying to look at that person eyeball to eyeball. Well, all right, folks, I've already given you one fib here. I do know this lady very well. I've known her for a lot of years. She told me something way back at the beginning that it took a while to sink in. She just felt like the head wasn't always there, that the emotions were a jumble. And as I've gotten to be more experienced at providing gender affirming care, I've really come to understand that, yeah, we have to have your head attached the right way in terms of getting your care. So in terms of what kind of a patient are you, we have to have all of you. And so let me reiterate what I said many times in our last episode. Your mental health provider is critical to your success as we move through your gender care. They are so doggone important that we just really cannot do our jobs as competent surgical and medical providers without your mental health provider. Now, as I just got done saying this, I'm going to have to tell a tale on me. All right, so when I started my gender journey and started on the hormones, I thought, I've been doing this for 40 years. I know all the ins and outs of all this. I don't need no stinking mental health provider. Well, folks, here's my admission. You know that old expression, you don't know what you don't know? Oh, by golly, that found me. I've been just awestruck by how much my poor brain has changed since I've been on hormones. Fortunately, I heeded my own advice, and yes, I started this journey with a mental health provider, and I'm so glad that I did. All right, so let's talk about the things that we're going to do for you as a patient. Remember, we're talking to all parts of you. We're changing you from the outside. If you're doing your surgical journey, we, as primary care providers, we change you from the inside out, and we change every part of you. But that's just it. We're changing you inside and outside, but with all of that, this thing is really critical. We have to have your brain in the right place, the right time, all the time. So it takes all of us as a team to do the right job to help you. So this is going to be my first foray to our DIYers who might be listening today. It takes all of us helping you to give you the best outcome as we go through this. Now, this is the why. Okay, you may walk out the door and say, oh, golly, there's something not quite right here. I wonder what that is. We're the ones that are trained as your healthcare providers to look for those things that are going to fall on you and hurt you somewhere along the line. I just wrote this on CDH for one of our members. We are trained to look for the elephants. But besides that, we're trained to look for the zebras that are hiding behind and eclipsed by the elephants. So that's our job, is to keep you out of trouble as we go through hormonal therapy. Now, let me say this a little bit different way. If you have a problem, don't ask your surgeon. Everybody knows that I bash my surgical colleagues a lot. If you've ever been around a bunch of surgeons, they have a hard time agreeing on anything, except if you give them a really big clue, they might get it right. Now, let's talk about how we're going to deliver care to you. This first philosophical line you've heard before, primum non nocere. Do no harm. So whatever we do, we want to do it caring and competent. The second one you've heard maybe a little bit different way, patientis venti primum. That means that the patient comes first. But if you think about it, these two philosophies are on different ends of the spectrum. We know what you want. We know that you want to get it, but we need to get it to you in a competent way so that we don't cause harm while you are getting what you want, what you need, and making you successful in your journey. Now, there's another way of saying it. My daddy gave me a cartoon, and this cartoon's a little bit spicy, but I promise it's not censored. But he gave this to me over 45 years ago, and it took me decades to really figure out what it meant. Again, you're a musician, and we're laying out this beautiful song of your life. You can do it right and make beautiful music, or you can try too hard, do it the wrong way, and yeah, it doesn't come out so well. Okay, so gender affirming hormones, 45 times you'll hear me say it, kids, don't try this at home and don't do it without adult supervision. But as many of the really good things I'm going to tell you, some of the bad things that I'm going to tell you, and some of the really ugly, horrible things I'll say, please, at the end of the day, understand that gender affirming hormone therapy, it's safe, it's effective. We employ this all over the globe, and this is why we do what we do. It's widely enjoyed. Okay, I have to explain a little bit of biology before we dump hormones in here. All right. And again, some people will want to argue some of these things, and I'm just going to lay out some general definitions. We know that the genetic humans that are XX and the genetic humans that are XY become different things over time. So XX humans tend to grow up in terms of what we recognize as the female, the feminine, cis female component. The XY will be those masculine male kinds of humans. But that's the thing, it happens over time. So we know that there's a difference between us humans from the time that we're born and even before that conception until we get to be old farts like me, that cradle to grave. There's a difference over time. Now, it even starts way back on the 7th day after conception. In that forming embryo, we know on the 7th day that we can get progesterone being elaborated in what becomes the posterior or the backside of a human, where the axial skeleton forms. Progesterone is what potentiates that part of the axial skeleton development. And we develop more and more over time. And we also know that there's this amazing transformation in us humans from the time of puberty, that 10 to 12, 13-year time frame, up until we become these mature adults, 21 to 23. Now, that's important because what we get out of gender affirming hormone therapy depends on where you start in that timeline. The earlier you start, that's the exposure, and the longer you're exposed to the hormones, the more masculine or the more feminine, in terms of your choice, that you're going to become. So earlier is better, longer is better. I'm going to make you a much cuter girl. I'm going to make you a much more masculine, handsome kind of boy the earlier we start. But remember, we've got some constraints here. So I'm only going to speak to us as adults. I'm just not smart enough to know how to help children. It's not what I do. There are some people who are really smart about that, and we have lots of arguments, but we're not going to go there today. We're only going to restrict ourselves to adults. All right. So we're going to start with the transmasculine. And I know our trans femme people are getting itchy. Let's hear about the femme, but let's talk about the masculine first. the one most important thing that both of us, both the transmasculine and transfeminine, need to know, this is a vial of testosterone. This is really potent stuff. Every molecule of testosterone in this vial is about 7,000 times more potent than every molecule of estrogen in this bottle. Okay? 7,000 times more potent. So with that said, my job in helping transmasculine is the easiest thing I do. I'm going to get you there, and I'm going to get you there fast, and you'll be really happy because it happens almost at warp speed. Okay, so all we need is testosterone to do the job. If we're going to do the job, how do we do it? Everything we do is parental. There's nothing that helps us by mouth. I don't care what you hear on TV. You're not going to get a 7-inch penis, and you're not going to get a 7-inch clitoris by taking a bunch of pills that you bought on TV or the internet. It doesn't happen that way. So we have to either inject you or give you patches or gels. The gels are kind of messy because you can cross-contaminate other people, but we've got lots of ways to do this for people who are needle phobic. Okay? Now, if that's what we do, what are our target levels? Well, we're looking for testosterone to be somewhere between 200 and 800. That's the normal cis male levels. But in terms of helping our transmasculine patients, we want to look for testosterone levels typically that are 400 to 700 nanograms per deciliter. These units of measure are pretty much worldwide. They're in the WPATH standards of care. Now, that's for injected. If it's transdermal, we look for pretty much the same numbers, but we have a way that, and when we do it, in terms of how we get the right numbers and understand the numbers. Okay, so we know what we have to do. We know how to get it, how to dose it ourselves, and we know what we're looking for. How much is it going to cost? Well, these numbers that you see up here are if you had to go buy this full retail, no insurance, you're paying for this out of your pocket. And these are as of February 2025 in the United States. The numbers are really not very different for our folks over in UK or Australia. I haven't checked in other countries outside of them, but they're pretty close. So our injected materials are somewhere, $8 to $30 or so. In the United States, we can't get the patch very well. They've been discontinued. We've had some other makers who've tried to bring some other things to market. We've not been successful very much. Other parts of the world, you all have much better access to that. The gel is also widely available, tends to be inexpensive, but again, kind of messy, and we can cross-contaminate people. All right, so we got the shots or we got the patches, and here we go. What are we going to get? And when the heck are we going to get it? Well, that's actually pretty easy for our transmasculine folks. Yep, you're going to get this pretty fast. Well, this is a Gary Larson cartoon, and I've had the fortune of meeting Mr. Larson twice. He's an individual who is parsimonious with words. When I saw this cartoon, I happened to have a chance to ask him, Mr. Larson, are you a supporter of the LGBTQ community? I saw this cartoon and I thought it was just incredibly insightful. And his answer was, Dr. Haggerty, you're a physician. I'm Gary Larson. I'm a cartoonist. And with that, he turned around and walked away. All right, so here we are. This is what we're going to get. Look at the things that we're going to get for our transmasculine patients and how fast they happen. we're talking a handful of months where we start to develop facial and body hair. We're starting to get increased muscle mass in our proximal musculature. The fat gets redistributed from the buttocks up into the chest area, etc. Menses stop pretty doggone quickly. The clitoris starts to enlarge, and that's really important for our transmasculines. We're going to ultimately get surgery. The voice starts to deepen. But look at this. Just a handful of months these things start. They reach their maximum benefit in just a couple of years. So we've got a great way to get them to the goal line really quickly. Okay, well, Dee, man, I love that. Bring it on. But if that's what we're going to get, is there something else that I ought to be thinking about? Well, yeah, there are a couple of things that are at least a little bad. Okay. Now, this comes directly out of the standards of care. Look all the way to the column on the right-hand side where it says the testosterone-based regimens. These are based on the things that we absolutely know for us as transgendered people. A lot of the levels and how we put hormones into you are based on what we know about the cisgendered individuals. But these complications are based on the things that we definitely know about us as transgenders. We know testosterone causes polycythemia, which is increase in the red blood cells. Oh golly, if you can't make sperm, you're going to be infertile, and it happens really fast. You're going to get acne. We start to have some pattern hair loss. Testosterone really bugs people and their blood pressure. As people gain weight, things change a little bit. We do actually increase the risk for sleep apnea in transmasculine individuals. And it's guaranteed we're going to mess up your cholesterol. We're going to mess it up some way or another. So if you take things like high blood pressure, high cholesterol, weight, let's say you throw a little smoking into the mix, we're probably increasing cardiovascular disease in these individuals. And that's not quite so great. And if you see way down at the bottom, the low bone mass osteoporosis, we haven't proven that in us as transgender, because again, we haven't been doing this so long for us as transgenders, but we definitely know that if you take estrogen away from cisgendered females, they get osteoporosis. So we're probably doing that to our transmasculine. Okay, so what else is bad besides things on that list? These are the things that we see a lot. Shots can be irritating for some folks. And yeah, at the beginning of therapy, we're pretty much going to nauseate the majority of people. We tend to cause swelling in the lower extremities for people who are on higher doses, maybe some headache. For people who have had anxiety or anger issues in the background, they really come roaring out in these folks that are treated with testosterone. The two things that I deal with the most in terms of the emotional impediments really are the anxiety and the anger management. Okay, so what things are really, really bad for the folks that are transmasculine? Well, we give them blood clots. And it happens. I mean, it doesn't make a difference whether you're a transmasculine or you are a cis male and we're giving you hormone therapy with testosterone. We increase your risk for a heart attack, stroke, and like I said, the blood clots. And I've seen this a couple of times, the cholestatic jaundice. We make things kind of sludge up in your liver. And yes, I've seen one case of hepatocellular cancer in a transmasculine individual. So yeah, bad things can happen. But again, done the right way, watching out for these side effects as we come along, that's how we mitigate the risk and the complications. Okay, So our trans femme folks, here it is. We're getting onto the rowboat for you. To do the job for our trans femme patients, we have to deal with two things. We have to put estrogen into you, and we got to get rid of that terrible testosterone. So all of the folks we just got done talking to, the trans masculine, they're saying, okay, send all that testosterone our way. Us trans femmes, we have to get rid of the testosterone. We either have to get rid of it or we have to block it from being produced. So we do have to do two types of medication to do the job for us as trans femme. Okay, so here we really do have pills, patches, and shots. So if it's a pill, it's estradiol. Patches, they work great. They're a little bit expensive here in the United States, and you usually have to use more than one. But the injected route is what most of us use. It's the safest, lowest risk, and we're going to find out it's really not very expensive. Okay, so it's either pills, patches, or shots. Down at the bottom, you see the anti-androgen. That's what we're doing to block testosterone. Here in the States, spironolactone is our go-to drug. We don't use the other agonists, the things that biologically target the production of testosterone. One, they tend to be a little bit expensive. And secondly, some of them are hard to come by in the United States. Some of them have more restricted use to the child and adolescent type treatments. Okay, so if we do that, what are we looking for? Okay, these are the levels that we find in cisgendered females. Okay, estradiol is somewhere between 100 and 200 picograms per milliliter. Testosterone, we want it to be below that 200 mark. We really want to get it below 50. Remember, 200 to 800 is what cisgendered males have. But we want to get rid of the testosterone. Yes, the lower you go, the better your estrogen gets to work in you. But we pay a price for getting rid of the testosterone, and we're going to talk about that in just a minute. Okay, so how much does this stuff cost? Again, this is full retail, having to buy it out of your pocket, no insurance, etc. Pills, oh by golly, the pill bottle costs more than the pills do when you get right down to it. The shots, really not very expensive. Some of us who have insurance copays, maybe $10. Actually, the injected material is a lot cheaper in the United Kingdom. A lot of people can get a vial between the equivalent of $20 US, maybe about $40 Australian. Now, those anti-estrogens, the spironolactone, again, dirt cheap. Bottle costs as much as the pills do. Now, here's the deal. In the United States, those GnRH agonists, those are pretty pricey. And most of us don't want to spring for that kind of money out of pocket every single month. So that's why here in the States, the spironolactone is the go-to medication. Okay, so, all right, we do it. We got the right levels. What are we going to get and when are we going to get it? All right, now, here are some things that as trans femmes, we really like, okay? We want to redistribute our fat. We want to move some things down here to the hips and the buttock. Couple of months, they'll start to happen. It reaches its maximum in 2 to 5 years. But let me also tell you, no matter how long you do this, how much you do this, we're not going to get rid of your hip dip, girls. If you want to get rid of your hip dip, you're going to have to purchase that from your local surgeon. Sorry, hate to burst your bubble there. We start to lose our muscle mass and our strength because we're taking away our testosterone. We notice that, this bicep, tricep, forearm stuff really starts to slim down. Our skin starts to get soft. We don't have as much oiliness in our skin, maybe a little drier. the feel of our skin. It gets to be a lot more sensitive. We are really happy the way we feel in this skin. Our face starts to fill out. Here's a question we get all the time on both the CDH and the TGH website. When are we going to lose our libido? And when is the penis not going to work anymore? It starts to tone down pretty doggone quickly. In 1 to 3 months, things are really mellowed out. And certainly by a couple of years, it's just not going to work. And for most of us, and we want to get rid of that silly thing anyway, we start to close off the sperm production as our testicles start to atrophy. That happens pretty quickly. But if you look at all those numbers for us as trans femmes, none of that happens as fast as the good things happen for our trans masculine compadres. All right? Biggest thing here, we don't get to change our voice on estrogen. That's not going to happen. We really have to turn to other directions, our voice training, which I obviously haven't been very successful with, or surgery to do that particular job. Okay? So, those are all pretty good things. Well, what are we not going to like, Dee? Okay, same table, but now we're going to look at the center column. These are things that we absolutely know about us as transgender feminine. Blood clots. Yep. Our medications really do increase your risk of blood clots. Even if we do it the right way, we're using the right amounts, it happens. We become infertile because we're not making sperm. If we're using spironolactone, our potassium level goes up. I guarantee you, we're going to mess up your lipids again, the triglycerides. And you know what? We gain weight. That question that you hear women is asking all the time, does my butt look big? Oh yeah, we're going to make your butt bigger because you're going to be gaining some weight back there and some weight in your thighs, etc. Okay. Now, we know that cis males that we're treating with testosterone, we increase their cardiovascular risk, their stroke risk. We give them gallstones. Of course, the penis doesn't work. And we know that we give cis males osteoporosis when we take away their testosterone. Even though we've given them estrogen, let's see, girls supposed to have estrogen, helps preserve the bone, but not for us as trans feminine. We really beat up our bones. So osteoporosis does get to be a bigger deal. And as clinicians, we are starting to see that quite a bit more. Statistically, we haven't been able to prove it because, again, we haven't studied, researched, done the epidemiology on us as trans femmes so much. Okay. Now, the one thing that we do know is, at least so far, we're probably not increasing beyond baseline breast cancer or prostate cancer. We do see these occasional breast cancers in our trans feminine patients that we're treating with estrogen. Okay, so what else is kind of bad that goes along with this? Well, the things that happen on estrogen is the shots can hurt. And yeah, we're going to make you gain fluid also. Let's see. Didn't we do that with our trans masculine? Well, yep, we did. And yep, we're going to do it to you. The higher doses tend to give us fluid retention more at the beginning of therapy while we're trying to also change some lifestyle factors. And by golly, we're going to constipate the bejeepers out of you with our estrogen and taking away your testosterone. Melasma is the patchy pigmentation, mostly here, the mask of the face and other pigmented areas on the sun-exposed skin. We really do start to mess up high blood pressure. We get mood changes, the depressions and headaches and things. And it's something that we see on a episodic basis during the allergy times there. We get much more asthma exacerbations in our estrogen-treated patients. And another thing, unfortunately, I'll have to put my eyeballs back on. The eyes don't tolerate contact lenses as well. It's both a change in the proteins that coat the eye as well as fluid. So many of us, as we age, as trans femmes on hormones, we can't wear contacts very well. All right, the things that happen with spironolactone, that first one up there you see, we're going to make you a saltaholic. Before you reach for a spoon or a fork or a knife, you're going to be reaching for the salt bottle. We change some of the distribution of the taste buds and things like that. So we really seek out salt. Spironolactone is what's called a potassium-sparing diuretic. So it hangs on to potassium, and sometimes our blood levels can get high. And I run into maybe 5 to 10% of our trans femme patients who can't take the spironolactone because we're making their potassium levels too high. We change the gastric acid secretion and the protective protein coating in the stomach. And so we see much more in terms of gastric ulcers in the patients that are treated with spironolactone. If you were a gout patient before you started hormones, we're going to make your gout worse, very likely. The blood dyscrasias means we change your white count, we change your red count, and we change your platelets. A modest amount, but we see it on a regular basis. It usually does not mean anything significant, but we do notice those changes. Now, particularly look at the last three: mental dullness, fatigue, and muscle loss. Yes, spironolactone causes that, but doesn't taking away our testosterone. Us old farts who have a normally low testosterone, that's one of the things that happens when we are testosterone deficient. We get mentally dull, we just don't think so well, we're fatigued a lot, and of course we've lost muscle mass. And it's hard to both statistically and clinically sort those things out. What belongs to spironolactone, what belongs just to the low T state all by itself. Okay, so those are a bunch of those nettlesome things, and you know what? We can deal with a lot of this. So one of the things that are really, really bad about estrogen therapy, blood clots. And by golly, we see them. We get blood clots in the legs. If they break off, they can get into the lungs. That's called a pulmonary embolism. And yeah, ladies and gentlemen, we die from those. And we've heard about that here recently on both the CDH and the TGH site. But we have to be really cautious using these medications. And just like Ghostbusters, you have to have someone to call when something isn't going right with your therapy. If you think you're having one of these things, we're the ones that help you out of a jam. The second one that you see up there, this is really peculiar to estrogen-treated gender patients, especially the oral estradiol. Now, let me say, I happen to know something very personal and firsthand about a retinal thrombosis. I was on shots, but COVID came along, and I got COVID. What's one of the things that we know about COVID? Well, it is what we call procoagulant. It causes blood clots everywhere in our body. There's a peculiar artery in our retina that the COVID tends to affect more. And when you put the estrogen of therapy in on top of COVID, these blood clots get to be an even bigger deal. So please, anybody who gets COVID, and you all know it's not going to go away, it's with us forever now. If you get COVID and you are either a transmasculine or a transfeminine patient, you really need to seek care, and you should seriously give consideration to the oral medication that we use to treat that particular virus. Something else that happens a lot, and we're seeing it kind of more these days in our trans feminine treated patients, gallstones. And by golly, those things hurt. A lot of us, think, gallstone is a simple thing. You go in, the surgeon takes out your gallbladder. But let me tell you something very startling about gallstones. Age unadjusted, gender unadjusted. For every 100 people who walk in the front door of a hospital with a true acute gallbladder attack, 8 of them, 8%, will not leave the hospital upright. Yeah, gallbladder disease kills people. So again, if things aren't going right in the gut, seek care and counsel. We also can give people pancreatitis, and it happens a fair amount, but it's also a very serious medical complication when it does happen. Estrogen lowers the seizure threshold. So if you've been on seizure medications to control your seizures, please make sure that your neurologist or whatever treating clinician that you're seeing to help you manage your seizures knows that you're on estrogen therapy so that you can be monitored a bit more closely and maybe have your medications tweaked a little bit. The gut is also not particularly happy sometimes with estrogen. We can, just like we do blood clots in the legs or the eyes, we can change the blood flow distribution and lead to a lack of blood flow in certain parts of the colon. And we can get this, what's called ischemic colitis. So inflammation, infection caused by a lack of blood flow. We talked about raising blood pressure. We talked about raising cholesterol. We talked about potentiating diabetes. You put those 3 things together, and what are the 2 really bad things that happen with those? Heart attack and stroke. That's the myocardial infarction and the CVA stroke. Here's another thing that is getting to be recognized more and more as time goes on, and we have both more cisgendered women and transgendered transfemme that are taking estrogen as we age. There is a greater increase in what we call the vascular dementias. We block up these little tiny nutrient arteries that supply the memory part of our brain. They're very, very little small arteries. You block off enough of them, you change the memory part of the brain, and that's dementia. Okay. So those are really the things that happen, and your healthcare team needs to be on the lookout, working for you, whether you're transfemme or transmasc, to help guard you against some of these complications or recognize them when they first happen. But remember, done right, and making sure that all of us as your healthcare team work together, gender affirming hormone therapy, it's really safe. It's very effective. We use it all across planet Earth. And again, the last thing that every one of us wants to take home from this, it's why we do what we do because we enjoy who we are, what we are, and what we have become with our hormone therapy. Okay, so I probably filled your poor little ears with all the things that you can hear. Liz, come on back up. Let's try to answer some questions. I've seen a couple of things scroll across the screen, and let's have our directors come help us also.
All right. Well, we did get quite a few questions, Dee, that popped in. And there's Vanessa saying hello.
I thought that'd be the best one to start off with.
Wow, Vanessa, wow.
All right. So let's see. I don't think we need, Dee, do we need these slides up anymore?
Let's go ahead and get rid of that. And I can see your lovely faces a whole lot better.
There we go.
And I'm sorry, I'm going to have to put on my eyeballs if I'm going to see these on the screen here.
Oh, no problem. So,
All right.
where do we start?
Right. Where's our first question? We had quite a few that popped up here.
Renee has one up here, and we just recently touched on it. Is that what's causing my small vessel disease in the right parietal region of my brain?
Where did that go?
Yeah, the estrogen may not be causing it, but it could certainly be contributing. Remember, if you have any of those background things like high blood pressure, high cholesterol, maybe smoking or diabetes, and then you throw estrogen in that mix, any of those things can lead to blocking of those little tiny small nourishing arteries up there in your brain.
And why we're getting a lot of questions we do on the sites. Can you explain the benefits of progesterone?
All right. And for y'all in the background, Liz has called me out on this one before. I didn't say anything about progesterone for a good reason, because for adults, it does not find its way into the standards of care as published in version 8 by WPATH. And there's a reason. We haven't been able to prove that progesterone in us older individuals does anything in terms of gender affirming care. Now, put gender affirming care off to the side for just a minute. What do we know about progesterone in cisgendered women? We know that it helps the sleep cycle. It promotes a better sleep and the deeper phases of sleep. We also know in cisgendered women that it promotes a sense of wellness, well-being, and helps elevate the mood. Okay, now that's what we know in cisgendered women. Well, now here we are. Let's bring that trans femme stuff back onto the table. But we're human too, right? If we have trouble with sleeping, it'll help or may help. If we have trouble with our mood or we need that sense of well-being, it can help. So yes, I do use progesterone in those particular circumstances, but not for us senior adults on hormones. Now, let's take us seniors away from the picture yet again. Let's go back and talk about our legal age early adults. Progesterone, yes, definitely makes a difference in terms of changing that bit of the body structure, pelvic structure, and lower bony prominences, etc. It makes a difference in terms of how those things develop. So yes, it is a part of the care in the earlier age. And oh, sure, I can get a whole lot more mileage with my young patients using progesterone. weight loss, just not so much.
Hey, Dee, we got a few questions about anti-androgens. Let me put this one up here.
Okay. Yes. There are some people who can't take the spironolactone for whatever reason. Now, we do have some other medicines, the bicalutamide. Now, we use this in treating cisgendered males with prostate cancer because we have to knock down testosterone for those who are testosterone-dependent cancers. The bicalutamide works, finasteride works, dutasteride works. Those things do help to cut off the testosterone. We pay a higher price a couple of ways. They're much more expensive than is the spironolactone, and they have a whole different peck of problems in many different ways than does the spironolactone. But we definitely do use bicalutamide in a fair number of people.
And this question here came up also, not exactly about an AA, but related.
Okay. Let me say, yes, all these blood pressure medicines can interact with one another. And sometimes you'll get unwanted adverse effects. But let me also take a little bit different spin on this question. We have to be very cautious about all of the things that we put into our mouth, whether they are prescription medicines or whether they are supplements, vitamins, things like that. Now, we have discovered, and we find out more and more, that so many things interact with one another. If you really don't need to have it going into your mouth, you're probably better off not putting it there. Now, let me ask you a philosophical question for which you can answer and I can't answer. Can you tell me that your supplements, herbs, whatever, do not interfere with your testosterone therapy or your estrogen therapy? It very well could. So why go there if you don't have to? But yes, specifically going back to that question, yes, all of the blood pressure medicines can have unwanted interactions or augmentations of their basic effect or benefit that may not be so good as a benefit.
Okay, and
we do have it where we get to where a lot of people ask, how big will my breasts grow while I HRT, and how long does it take before they fully develop to where they will stop growing?
Okay. This is one of those questions that I get pummeled with on a regular basis. Now, most of us want to have breasts, okay? And we like them to fit our body habitus and help us in terms of how we view ourselves. I'm going to go back to one of those slides that I put up kind of in the early part of the presentation. How big your breasts are going to get and how much development you're going to get depends on when you start. If I start you on estrogen therapy in your late teenage years, early 20s, you're really going to be that person who will typically get full B or C, okay? And then, that growth is going to be over a period of a couple of years, typically 2 to 5, to get to the maximum benefit. Now, if you're a dumb old person like me who didn't start taking hormones until age 65, I'm never going to get C's out of my hormones. Okay, so the earlier you start, the more breast you're going to get than the later you start. The longer you're on it, the more you're going to get. Part of the answer is also genetic. If you come from a family of small-breasted individuals, the chances are you're not going to be double Ds. If you come from a family that is more generously endowed with breast tissue, you will probably, given enough time and exposure, starting early enough, have larger breast development. Does that help?
Actually, it does, yes.
Let's see.
That is kind of a little spin off of that. Someone sent me a message on the site a couple of days ago, and her particular point was, I saw a surgeon about breast augmentation, but she said that she wouldn't do my surgery until I had been on hormones for a while longer. A couple of my friends had the same experience. Why won't the surgeon do surgery when I'm ready for it? I know if I have my breast surgery, it's going to make me feel right. Okay. That goes back to that philosophy, and I'm glad your surgeon is thinking about it. The primum non nocere, do no harm, and the primum went the primum. The patient comes first. Okay, so you, the patient, want to have these breasts, but remember, breast development is based on when you start and how long you've been on hormones. If you've only been on hormones for 6 months or so, you probably don't have very much, breast tissue development. The more breast tissue development that you have before you go to see the surgeon, the more natural the appearance is going to be after your surgery. You're going to get a much better benefit. And that's a really hard thing to tell someone in the throes of their dysphoria when they are moving along their gender affirming care, that yes, we know that surgery is the right thing for you, but you know it's just not the right time.
I'm going to put this one up here, Dee. Just a little bit of a shifting gears here.
Okay, when do the counts stop changing? That's a hard question. I'm going to have to give you this one just based on my experience, because I can't say that I have an article that I can quote right off the top of my head. It can happen at any time that you're taking your hormones. We tend to see most of the adverse effects earlier on in therapy. Just like if you start a new blood pressure medicine, a new diabetes medicine, most of the side effects happen when you first start taking pills. But remember, the hormones are fundamentally changing what we are from the inside out. And we're going to age with time. So we change all of the time. The human that I am today is not the human that I was 10 years ago. So I see these changes in the white blood count, the red blood count, and the platelets happening anywhere along the treatment timeline, either when they first start taking medicine, or even some of my folks who have been on treatment for as much as 20 and 30 years. And that's why you just can't kind of get to what you think is a goal and wave bye-bye to everybody on your healthcare team. We're with you for the long term for exactly things like this question.
Okay, Dee, I do have one. This is kind of a two-part question. It comes from our owner of the site, Vanessa Law. The first part is, how do you ensure a post-transition transgender woman gets sufficient testosterone?
Okay. Couple of things embedded in this. yes, the body still produces testosterone, even if you've had an orchiectomy. We know that cisgendered women who are overweight, they produce a higher content of estrogen and a higher content of testosterone by what's called peripheral fat conversion. Okay. Now, in cisgendered males, we still do produce testosterone. Most of it, if you've had an orchiectomy and taking testosterone even on top of that, we still do peripheral conversion also, and we do have some production in some other cells of our body. But here it speaks again to the long term of your care. You still need to be monitored, and you still need to have blood testing along the way. Now, once we kind of get to that stable level, blood tests instead of every 3 months get to be maybe once a year. Now, here's a harder question. Take a cisgendered male. We know that their testosterone falls off every single year as they age, and it gets to some low-level plateau. Right? So, as a transgendered female, should your testosterone level go down also? Well, by golly, we really don't have a great answer for that. Some of us err on trying to keep the testosterone level in that 200 to 800 range. Some of us say, well, now you're in your 70s, you've gone through your medical transition, your surgical transition. Let's not worry about putting any more testosterone into you. I don't know that either one of them are correct, because we're still trying to figure all this stuff out, Vanessa. We're smart, but we're getting smarter every year as more of us are in the medical milieu.
All right, we got a question here. Actually, I posted this one, so I'll put this up here. I'm curious about your feelings on monotherapy.
Okay, there are some people that don't want to block testosterone. I get it. It really depends on what the individual's goals are. Remember, our job is to help you. The standards of care are what we call prescriptive. They are not proscriptive. That means they're not prohibitory. There's a lot of right ways to get to the right answer. Typically, you're not going to get as good a benefit on monotherapy with estrogen, because remember what I showed you at the beginning, every molecule of the testosterone in this vial, about 7,000 times more potent than the estrogen in those pills. So if you still have that pesky testosterone floating around, you just may not get all the estrogen benefit. But there's another way out of this. And I mean, my patients hear this all the time. Get rid of the gonads. Orchiectomy. And it's a great way to stop the testosterone without taking a pill.
Okay, I do have one here that might be pertinent to this. Comes from Vicky. Do you get to a point where you no longer need to take meds when your body starts to produce estrogen on its own?
Probably you're not going to get to that point. Now, there are many, many people who elect, okay, I've been at this for a bunch of years. I know that menopausal cis women don't take hormones and they're not making very much, I'm going to stop. We're really not going to do a very good job of producing our own, except in those people who are obese. Some of us can make a little bit of estrogen, but most of us just don't. So the average person is probably going to need medication for the long term, maybe not for the rest of their lives. And some of us, as we withdraw from the estrogen or our estradiol levels fall, we lose a sense of well-being. We don't like it. We may not get the hot flashes and those kinds of things, but that loss of well-being is a lot because it changes the quality of life. So all I can tell you is, Vicki, you have to do one of those numbers. You have to feel your way through it over time. What do you feel and how are you doing versus what the speed check is with your medical provider?
I'm going to put this one up here, Dee. I think this is a good question. We just led into that a little bit. I think this is a pretty common question with a lot of gals. What happens if they stop?
Okay. There are a very definable number of people who start on hormone therapy and then for whatever combination of reasons, they stop. Many, but not all, of the changes will revert. You may not have a complete reversal. Some of the things that tend to persist and we don't particularly get back, if you have decrease in testicular volume, sperm reduction, loss of erectile function, somewhere around half of those folks is the best number I can put my finger on, won't get those back. So you have to decide you're in it or you're not. And that's a really tough decision point to go past. And that's why I pounded on everybody about your mental health provider. You really need to know before you go that it's the right journey for you to be on. Of course, life changes, things happen. We either have to stop therapy sometimes or for whatever cataclysmic reasons. You're not going to be the Wicked Witch of the West. The house isn't going to fall on you in the next 10 minutes. You may not like some of the reversions, but you probably won't get back to where you started.
Okay, here's another one that pertains to meds and blood clots like we've been talking about. This person, Matt, he's 67, has a family history of blood clots, father, brother, nieces. How worried should they be to start transfen meds?
Well, some of our listeners have been down this road with family members, and there are many of the blood clotting disorders. The factor V people are among them. If you have this family history, you should really be tested for the factor V laden or the other subtype clotting disorders. Now, with that being said, yes, you really need to be concerned. Now, we are truly decided that I must be on hormone therapy. I know with my age and this family background, I have an increased risk. What can I do to lower my risk? Well, one of those things to lower your risk is don't take the pills, do the parenteral, do the injections, which very significantly lower the probability. Doesn't erase it, but it lowers the probability of clots. Or if it really is a significant factor, or you have Leiden or one of the other clotting disorders, you can take an anticoagulant. And there are many anticoagulants out there that can do the job. So it's really, that's a very difficult question that you and your physician really need to be eyeball to eyeball on, and asking that hard question and coming up with the answer that's going to help you if you are in fact going to be on hormone therapy.
Hey, Dee, I'd like to just add a little bit to this question. It kind of strikes home for me a little bit. I'm in my 60s, and I started doing hormones when I was in my 60s. I am factor V Leiden positive. I have had DVTs. They've all been trauma related. But I knew when it was time for me to transition, I knew, this was something I needed to do. It's something that I needed for my mental health. And, so I started looking into what my options were basically. And I had a conversation with my physician. I went to go see a blood doc. The specialty escapes me at the moment, but yes. And, the advice that I got was, well, number one, stay away from oral medications. I'm doing injections. Number two, they said, because you do have a family history of blood clots, I did test positive for factor V. You can also look at an anticoagulant. And so I have been taking an anticoagulant called Xarelto for 5 or 6 years now. I actually started taking it before I went on HRT. But when I started going on, when I started to do HRT, I thought, well, maybe there's something I should be taking instead. And my doc actually told me, no, this is probably one of the best ones for you to be on. So I just wanted to throw that out for the benefit of anyone that finds itself in that situation.
And like I shared with y'all, I had a retinal stroke. I lost half of my vision in my left eye. And by golly, I'm sure as hell not going to stop my hormone therapy. Mm-hmm. So what are the alternatives? Okay, you take the anticoagulant. And I'm happy putting that additional medicine in my mouth every single day, because by golly, I sure do enjoy my hormones because they have changed our lives. And whether, the Matt, we're talking about testosterone or estrogen, you do have alternatives in terms of these anticoagulants. And certainly your physician can help you with that. It's common. Or let's say it's not uncommon.
Okay. Since we're talking about older trans people being on medicine, we do have this question from Stacy. Is there an age where transitioning is not recommended? I'm older than when you started.
I'm going to let you take that, Dee, but I have an opinion on
that. Stacy, God bless you, honey. If this is what's in your heart, if it's what's in your soul, if it's what's in your mind, there's no reason not to transition or to fail to transition. Part of my double negative. Sister Mary Joseph would have a fit with my double negative. But remember, if transitioning is right for you, we're talking about a significant mental health action item here. So really, I can't tell you that there is any age limit. And honey, I'll tell you, I have started an 83-year-old on estrogen therapy. Okay. We knew what the risks were, and we knew what we were getting into, but it was right for that person. And we just deal with it as it is. And we invest more time in our older trans patients, but all I can say is pursue your heart and take strong counsel with your mental health provider and your physician.
I think I'm going to pop this up here. There's a question I asked, but I think it's something that's worth discussing a little bit.
Yeah. Pretty much, I'd be willing to bet that almost all of us who walk this path with hormone therapy, we know, we are fundamentally convinced it was the, in capital, bold, italic letters, the right thing to do in our lives.
Mm-hmm.
It so much improved the quality of our life. It improved our mental and emotional well-being. I'll put a little bit of a spin on that. For most of us, we will also admit getting rid of that pesky testosterone makes us much better humans.
So I agree. Totally agree. It was life-changing.
There you go. I think we all agree.
That one of our folks at CDH sent to me, and I shared this with y'all last night. And we get this on a regular basis on the site, whether it's CDH or TGH. Is it true that healthcare workers really don't care what you wear? Your panties, your painted nails, your slips, whatever. Is it true that they don't care? We don't give a rat's furry tail what you look like. Now, come on. We treat people who smell bad. We treat people who look bad, but we treat humans. We're there. Technicians, nurses, physicians, the clerical people, they're there because they love that part of life. They love that profession. They're in the service world. And you know what? I've said this to my colleagues before. Some of the very best compliments I've ever gotten have been from the nurses who saw my panties or my slip when I wasn't presenting as mask, or when I wasn't presenting on them and I was, underdressing. They're incredibly kind. Physicians, nurses, we accept everybody who comes to that door. And please don't feel like you're going to get second-rate care at the emergency room or urgent care or going to your doctor. We love you anyway. Okay, yeah, I'm saying that because I'm a transgendered physician, but we love you the way you are.
All right, so we're running out of time, but I think we might have time for one or two more questions. So, Kimmy, you have one ready to go here?
I can put one up real quick. That's easy. It's let's go with this one then. My primary care doctor is concerned because of my elevated white cell count, my platelet count in the last 2 months. How would that affect me going on to HRT?
Okay, so if this is a pre-existing condition, you have to have an answer why. Well, a lot of these things are idiopathic, which means we're idiots and we don't know what the pathology is. If it's not a terrible concern, if we're not worrying about the leukemia that's getting ready to pop out of the box, there really, I won't say for most folks, is an absolute prohibition to starting on hormone therapy. But again, you got to step through this with your providers. If you have a hematologist, they need to be on board and they need to be knowledgeable. Okay, you're taking testosterone or you're going to be taking estrogen. Your primary care provider, all of your healthcare team really needs to know as you go forward together. But for a lot of people, and I've seen a bunch of folks with elevated platelet counts, white blood counts, that we've started on a therapy de novo. We simply pay attention. Now, every once in a while, we'll get a person that we start and we've that wasn't the right thing to do. Things got worse. Okay, we got to stop. Well, but that's getting to the right answer, working together. So I won't say just based on that little bit here in the question that it's a game stopper.
Okay, Dee, I have one more. This is going to be probably a good place to end the Q&A. How worried should a trans femme or trans masculine person be with site injection reactions?
They haven't. I think, all right, here's a qualitative value-laden statement. I think most of the reaction issues lie up here. Many people have needle phobia. Now, the injections, yeah, they hurt a little bit. Liz and I mean, we've been doing this for a while, and I don't relish every shot that I get. They used to bug me a whole lot more at the beginning. But sometimes, you'll get it a little bit different place in a muscle or closer to a nerve. It'll bug you for a while, but they're usually not terrible. These tend to be just kind of pesky nuisances. There's a difference between harm and hurt. Not everything that hurts is going to cause harm. Okay.
Okay, I think that is a good spot to end. Are you okay with that, Liz?
Yeah, we have a whole bunch more questions here, and
we're delighted that we do.
Yes, we do. And on that note, I just want to make note that we are going to be having another third webinar for gender affirming hormone therapy, where we're strictly going to be answering questions. So we've got an overflow of questions from today. I expect there'll be some more questions that'll come in after the webinar is finished, and we will address those then. So if we didn't get to your question today, we will get to it for sure. We will get to it at the next webinar, which I believe tentatively we're planning on 2 weeks from today. If for whatever reason we can't, or perhaps we will answer it directly. We may send you, Dr. D, perhaps we'll send you a private message to answer your question. So, but we are a little bit over on time. It's going for almost 1:40 p.m. on the West Coast here in San Diego. So thank you everybody for being with us. Really appreciate it. This has been really helpful and informative. Dee, thank you so much. Kimmy and Jasmine, I know Jasmine is kind of hiding behind the scenes right now, but thank you so much for all your help.
That's okay.
All right.
Behind the scenes is what we needed. I want to thank you again because it has answered a lot of questions that people have, and it probably brought more questions that people have. It probably brought more questions that us that have been on it have also come up with as we're listening to Dee and listening to her answers. It's possible on the Q&A we'll have our own questions.
And I'll sit here to answer questions as long as you all want. Thank you so much for having us, and thank you for being with us today.
All right.
Okay, and this is the whole group that presented this
today. Jasmine. All right.
Me, and you all have a good afternoon, and hope to see you in the next one.
All right. Thank you, everybody. Bye-bye.